You ran the background check, you verified their references, you hired a highly qualified specialist, and now they're doing absolutely nothing. That idle time is not a symptom of low patient demand. That provider is sitting in limbo, unable to admit patients or perform procedures, waiting on privileging approval. According to Medallion's research, every day a provider waits on privileges costs your practice nearly $1,901 in deferred revenue. Expanding to a monthly view, MGMA data shows this drain hits an estimated $10,122 per provider per month. Treating this credentialing wait as a bureaucratic pause masks the reality. It actively bleeds practice revenue. Administrators typically blame slow credentialing committees, but the committee schedule is a fixed constraint, not the root cause. The actual source of the delay is a mechanical failure in the application process, known as the packet bounce. Every hospital credentialing committee reviews applications against its own highly specific medical staff bylaws. These dictate the required documents, case log volumes, and privilege grid structures. A generic application packet built without specific knowledge of those bylaws will bounce back from the medical staff office. Most credentialing committees meet monthly. Missing a meeting due to a bounced packet forces a hard 30-day jump. Layered on top of the standard 50 to 90-day review period, a single error can create a massive 150-day cumulative delay. Submitting generic packets initiates a costly cycle of trial and error, directly extending the timeline of your lost daily revenue. Most practices try to solve this by assigning the entire credentialing burden to a single in-house coordinator. That single employee is often expected to manage multiple providers across various hospital systems, simultaneously tracking dozens of shifting requirements. The pressure creates an industry-wide staffing spiral. Credentialing teams experience a 15.3% turnover rate, higher than that of nurse practitioners or physician assistants. When that coordinator leaves, critical institutional knowledge regarding specific hospital bylaws and office contacts leaves with them. The remaining staff are left manually calling hospitals to decipher requirements, often receiving conflicting answers between reapplication cycles. Relying on a constantly churning in-house team makes the bylaw mismatch and the resulting packet bounce practically unavoidable, and hospital privileging is only the first hurdle. Once those privileges are granted, practices face payer enrollment. Standard payer enrollment timelines stretch an additional 90 to 120 days before a provider receives an effective date. This creates an operational trap. A privileged, unenrolled provider can legally see patients, but the practice has no way to collect reimbursement for those services yet. Payers enforce strict allowable claim windows and often reject retroactive claims. If the enrollment timeline exceeds that window, the claims must be written off entirely. Slow hospital privileging pushes subsequent payer enrollment close to expiration windows, leaving the practice absorbing uncompensated care costs. To eliminate the bounce risk, modern practices are migrating from fragile in-house teams to a dedicated outsourced credentialing service like Staffingly. Instead of relying on a generalist, you get a dedicated specialist who already possesses the destination hospital's rules. They utilize AI to handle the consistent structural assembly of the application packet. Raw provider data enters the system and automatically cross-references against the destination hospital's specific bylaws and case logs. This automated precision engineers a packet that drops perfectly into the committee's review checklist on the first try. Outsourcing shifts a practice from reacting to administrative errors to ensuring first-time bylaw compliance. Let's look at the direct financial comparison between maintaining the in-house status quo and switching to the outsourced model. Once you factor in benefits, payroll taxes, and training, a single in-house credentialing coordinator costs between $65,000 and $95,000 annually. This side-by-side chart reveals the overhead gap. Next to the $65,000 in-house cost, Staffingly starts at approximately $20,700 a year. Below it, the speed metric highlights the operational difference. Standard trial and error takes months, while the outsourced team ships in exactly 7 days. Accelerating that timeline directly rescues the $1,901 in daily deferred revenue, otherwise lost to a packet bounce. The fractional upfront cost of an outsourced specialist pays for itself by immediately plugging the daily revenue leak. Transitioning to this new model does not require a long operational pause. A practice goes live in 14 days. moving rapidly from discovery and baseline verification straight to targeting the first committee deadline. The service also covers post-privileging, providing automated tracking for FPPE and OPPE compliance evaluations. Proactive evaluation tracking is mandatory. Missing a review cycle creates compliance exposure and stalls future recredentialing. And as this dashboard illustrates, provider data is locked down through enterprise-grade security protocols, maintaining strict HIPAA compliance alongside SOC 2 Type 2 and ISO 27001 certifications. If your practice is losing quantifiable daily revenue to hospital delays, migrating to an outsourced specialist via a risk-free 14-day pilot is the definitive financial fix.